Well, I thank you for standing by. At this time, all participants are in a listen-only mode until the question and answer session of today's conference. At that point, if you'd like to ask a question, please press star followed by number 1. This call is being recorded. If you have any objections, you may disconnect at this time. Now, I'll turn the meeting over to your host, Renee Sednew. You may now begin.
Thank you, everyone, for joining us on Friday, and also thank you for your patience as we got everything set up for our webinar. My name is Renee Sednew, and I'm a Quality and Systems Improvement Director at the American Heart Association. I'm based in Illinois, and I focus on stroke and atrial fibrillation in the state. Really pleased today to have a webinar on Get With the Guidelines AFib, and we have a wonderful guest speaker who I will be introducing in a minute. As an overview, today we're going to hear from our guest speaker, Dr. Annabelle Volkman. She's going to talk about AFib disease burden as well as some topics focused on population disease burden. And they're also going to talk about our AFib quality improvement program and share some resources. Thank you all who submitted questions ahead of time. We will address questions at the end of the webinar, and everyone will be allowed to also bring up questions. So thank you again for submitting those. So next slide. So everybody was able to sign in, call in. Able to move to the next slide?
Nope, doesn't seem to be. Oh, there you go.
Thank
you.
Thank you.
When you want me to move to the next slide?
Sure, you can go ahead and leave it there. Thank you. So we're so pleased today to have Dr. Annabelle Volkman. She is a professor of medicine and senior attending physician at Rush Medical College and Rush University Medical Center. She's also medical director of the Rush Heart Center for Women. Dr. Volkman received her medical degree from Columbia University College of Physicians and Surgeons in New York City. She did her residency in internal medicine at University of Chicago Hospitals and Clinics and her cardiology and clinical electrophysiology fellowship at Northwestern Memorial Hospital in Chicago. She is board certified in internal medicine, cardiovascular disease, and clinical cardiac electrophysiology, and a fellow of the American College of Cardiology. Dr. Volkman's current research interests include preventive and management strategies of atrial fibrillation, especially antiarrhythmic drugs, anticoagulants for the prevention of stroke in atrial fibrillation. She is an active member of the American Heart Association, American College of Cardiology, and Heart Rhythm Society, and is currently education lead for the Women in Cardiology of the American College of Cardiology. Dr. Volkman is a board member and past president of the American Heart Association Metro Chicago Board of Directors and is currently on the Midwest Affiliate Board of the American Heart Association. She is active in efforts to increase awareness of heart disease in women. She has been a prominent leader of the Go Red for Women movement, has received numerous awards from Rush University Medical Center, American Heart Association, Girls in the Game, and the American Hall of Fame. I know a lot more about Dr. Volkman, but again, we're just honored to have her here to join us as a guest speaker on the webinar. So welcome, Dr. Volkman. The floor is yours.
Thank you so much, Renee, and thank you for that very kind introduction. Good morning, everyone. I hope everyone can hear me. As Renee said, I am an electrophysiologist, but when I started doing the Heart Center for Women, I stopped do procedures, but I still did a lot of research in atrial fibrillation. So it's near and dear to my heart, and I just wanted to give you some background information about atrial fibrillation. So with that, I'm going to just talk about how prevalent atrial fibrillation and flutter is in the whole world. As you can see from this slide, the yellow and the blue have a certain prevalence, about 250 to 625 per 1,000 people. But you can see North America has the red coloring, which means that they have the highest prevalence. So Americans and Canadians have the highest prevalence of atrial fibrillation and flutter. So it's a big problem here in North America. And in the United States, we have a lot of people with hypertension that can lead to the atrial fibrillation. So it is commonly seen by every every part of medicine, whether you're a surgeon, you're a nurse or nurse practitioner, anesthesiologist, or doctor, internist, or cardiologist, you will see patients with atrial fibrillation. So all should know how to take care of these patients. And this slide shows the incidence of atrial fibrillation in the United States among women and men. And what this slide shows is that women have an increased risk of getting atrial fibrillation from one decade to another. So the left side of the graphs are from 1998, if I can do that correctly. It's from 1988 to 1997. And then the right side of the graph is 1998 to 2007. As you can see, the red bars are the women. So we have an increased incidence. So there are more women getting atrial fibrillation, and there are a little bit less men getting atrial fibrillation, but it's really becoming more widespread. The prevalence means that we're increasing the incidence of atrial fibrillation in both women and men. So unfortunately, we are going to see more and more people as people get older, which is another risk factor for atrial fibrillation. As our population ages, we're going to be seeing a lot more atrial fibrillation in our offices and hospitals. Data as a primary discharge diagnosis, atrial fibrillation is really very high on the list. It's the most common arrhythmia diagnosis as a primary discharge diagnosis. And this slide says approximately 45% of patients are males. That means that 55% were females. So there are a lot of women getting atrial fibrillation. Unfortunately, people think that atrial fibrillation is a man's disease, just like heart disease is a man's disease, and that could not be farther from the truth. It is a disease that affects both men and women. It's just that women get it a little bit older than men, but there are so many women who are older and live longer that there are actually more women with atrial fibrillation than men. The age for men was about 67 years, and the mean age for women was about 75 years. One of the big problems with atrial fibrillation is the stroke risk. And stroke with atrial fibrillation is very disabling. As this slide shows, the blue bars are the stroke disability in patients with atrial fibrillation, and the bars are patients' stroke disability if they don't have atrial fibrillation. And it's easy to see that the blue bars are much higher than the red bars, and that the stroke disability is very, very high when they have stroke from atrial fibrillation. So the disability is 80% when they have atrial fibrillation compared to 40% in the non-atrial fibrillation. And it gets a little bit better after about a year, but it's still very disabling, so that after about 12 months, 25% of patients who've had a stroke from atrial fibrillation have severe disability. Fortunately, they require a lot of care from not only the spouse or the significant other, but from the whole family. So it affects the whole family. Atrial fibrillation cause larger strokes. They have larger infarcts, and they also have higher mortality rates, so that the hazard ratio is 1.884, which means that they have 84% higher risk of dying when they have a stroke from atrial fibrillation compared to patients without atrial fibrillation. So not only does it cause severe strokes, it causes deaths when they have atrial fibrillation stroke. Another thing that comes up is when somebody has a stroke from atrial fibrillation, even though it's an ischemic stroke, which means they're not getting blood flow to the brain, some of this will transform to a hemorrhagic stroke. So when somebody has an ischemic stroke, they're ones that will have a bleed stroke, because when brain tissue dies, it tends to bleed, and it can transform the ischemic stroke to a bleeding stroke. And compared to non-atrial fibrillation strokes, atrial fibrillation strokes tend to transform 29% compared to 5%, and that's significantly different. Speaking of hemorrhagic stroke, we were all very concerned about hemorrhagic stroke when we were putting patients on warfarin. Back in the 1990s, we were studying, I was part of the studies to look at whether warfarin versus aspirin versus nothing was good to prevent strokes in patients with atrial fibrillation. And as you know, many studies were done, and it showed that warfarin was superior to aspirin and superior to nothing when it came to atrial fibrillation. As a result of those studies, you can see in this graph the yellow bars, and the yellow line shows the increase in warfarin use from 1990s to 2007. And we increased the use of warfarin. You can see the blue bars, the ischemic strokes are starting to go down. And like I said, ischemic strokes cause hemorrhagic stroke. And when initially we were starting warfarin patients, we were afraid that we were going to increase hemorrhagic stroke. And the opposite happened. Even though there's only a small percentage of hemorrhagic strokes compared to ischemic strokes, you can see that the lines, the red lines, are starting to also decrease. The more we use warfarin, the less ischemic strokes we had. We also saw a decrease in hemorrhagic stroke, because most of the strokes were from ischemic strokes. So it made a lot of sense, and it really was very comforting to us that as we increased the use of warfarin, we were not seeing more hemorrhagic strokes. So how do we predict who's going to have a stroke when they have atrial fibrillation? The initial score that we used was the CHAD score, which looked at patients who have heart failure, hypertension, 25-year-old patients, diabetics, and patients with strokes. And we calculated the risk score. And who has a CHAD score of 2 were anticoagulated. Unfortunately, this CHAD score algorithm was not that accurate. It was not predicting as well as some of the other algorithms that we are now currently being asked to use. It's called the CHADS2 VASC score. It is on the right-hand side of the. We expanded on the CHAD score by adding V as vascular disease, so anyone who's had a prior MI, or peripheral artery disease, or any aortic disease, aortic ruptures, were all included as a risk factor. We all added people who were 65 to 74 with a score of 1, and we increased the age of greater than 75 or equal to 75 at 2. And then we knew from many, many studies that female sex, being a woman, was also a risk factor. When somebody has atrial fibrillation, the women tended to have more strokes compared to the men. So they added female sex as another risk factor. In this scoring algorithm, it increased the probability of predicting somebody who's going to have a stroke. So now use the VASC score as one of the things that we have to assess when somebody has atrial fibrillation. A man or a woman has a CHADS VASC score of 2, they also should be anticoagulated. Interesting that the American guidelines want to use a CHADS VASC score of 2 in women and men, but in the European guidelines, they use CHADS VASC score of 1 in men and 2 in women. So they really basically want us to anticoagulate everybody. So this is a CHADS VASC score that we are in the guidelines asked to use to calculate the risk. But I think there could be some improvement that should be coming along in the near future to help us predict even more. So we're not anticoagulating the patients who are really at low risk and really anticoagulating the patients who are at high risk. So why do women have a higher risk of strokes when they have atrial fibrillation? There are many different reasons, and this article was looked at why women have a higher risk of strokes. And I like this slide because it shows that there are many different reasons. As we talked about, women are usually older when they have atrial fibrillation. And the older you are, the higher your risk of stroke is. So that may be one reason why women have a higher risk of stroke. And women have hypercoagulable states. As women, we are supposed to bear the children, and we have menses on a monthly basis until menopause. And these hormones actually make us either more hypercoagulable or not as coagulable, because we have to shed and we have to our uterus have to be able to do the bleeding and the non-bleeding on a monthly basis. And this may have some role in our increased risk of strokes, even without atrial fibrillation. There is another variability, another factor that is more labile in women for some reason. And this increase and decrease of blood pressures can increase our risk of stroke. As you know, when you try to calculate the risk of stroke, either with the ASCV guidance or with atrial fibrillation, the higher the blood pressure is, the higher risk of stroke is. And women tend to have more labile blood pressure. And so this visit variability may be another increased risk. Women also tend to have a higher BNP or BNP, and they also tend to have less optimal risk factor control. So for all these reasons, women have a higher risk of stroke. They have atrial fibrillation. Unfortunately, women are less anticoagulated when they have atrial fibrillation. Even though warfarin was found to reduce the risk of stroke in women by 84% compared to 60% in women, women at the age of 75 years were 54% less likely to receive warfarin and less likely to receive aspirin. And I say this often, where doctors are afraid that these frail old women are going to fall, and so they don't want them to be put on anticoagulation. And there was actually a study that showed that a woman has to fall 300 times to offset the benefit of the warfarin. And I tell my residents and fellows all the time, please don't use fall as an excuse to use anticoagulation for these women, because they're the ones who would benefit the most. When we use aspirin for women, it's not as good as when we use it for men to reduce the risk of stroke. For men, if we use aspirin, the risk of stroke is decreased by 44%, but in women, it's only reduced by 23%. So all these reasons, I think we really need to try to anticoagulate a patient that needs anticoagulation and not use different reasons not to anticoagulate them, because they are at higher risk. So with a trial called the AFFIRM trial, which was comparing rate control versus rhythm control with atrial fibrillation. But this slide shows a sub-study that looked at mortality. This is the probability of survival free from stroke in men and women in the AFFIRM trial. And as you can see from this slide, women tend to have less survival when they were related even with warfarin. So women tend to have higher risk of strokes and death even when they're anticoagulated with warfarin. So do the new anticoagulants work better than warfarin for women? Well, this meta-analysis study was done by a group of radiologists, and actually Dr. Sharma is one of my partners, and I've talked to him about this great study that they did. Saw that the AFFIRM study showed that women, even on warfarin, had a higher risk of stroke. And they looked at the data on women who were getting novel anticoagulants such as Paxa or dabigatran, Aptaban, or zimalagatran. I'm sorry, not zimalagatran, but rivaroxaban. So dabigatran, Apixaban, and rivaroxaban were looked at to see if there was any residual stroke risk in women compared to men, either novel anticoagulants or warfarin. I saw that when women were treated with novel anticoagulants, they did not see this disadvantage in women. So in this meta-analysis, there's equivalent efficacy of stroke prevention in men and women. I'm not showing, and there was also less incidence of major bleeding in women with the novel anticoagulants. Another meta-analysis study, or actually there was another registry study, unfortunately, that has just recently been published, and it showed that women did tend to have more strokes. But I think on the overall, more studies are showing that women do better on novel anticoagulants than being on the warfarin. And people ask all the time, why do women have more strokes than the men when even on the warfarin? And sometimes I think that they saw actually was that women tended to have more procedures done like breast biopsies or colonoscopies or dental procedures where they were taken off the warfarin and started on the warfarin after the procedure, and this taking them on and off seems to be associated with an increased risk of strokes and bleeding. So this anticoagulation on and off seems to be a big problem for women. Unfortunately, the most recent registry looking at the use of oral anticoagulants for atrial fibrillation, the NCDR study, or the Pinnacle Registry, showed that there are still sex differences, and that they were seeing that among women with atrial fibrillation, they were less likely to receive oral anticoagulants at all levels of the CHA2DS2-VASc score. And despite increasing the use of the novel anticoagulants, they are still seeing a lower rate of oral anticoagulant use compared to men over time. And that's why I'm emphasizing anticoagulating women, because I think that a lot of doctors and healthcare providers are more reluctant to use these oral anticoagulants in women, and I think we're doing our women patients a disservice. So I think that we really need to be cognizant of that fact and anticoagulate or offer anticoagulation to men and women who are appropriately should be anticoagulated. Slide is look at whether oral anticoagulation is increased over time. And since the 2014 guidelines for atrial fibrillation, we're not seeing an increased use of oral anticoagulants. What we're seeing, though, is that there is a shift in the use of oral anticoagulants. There are less people being started or being anticoagulated with warfarin, and more are being started on novel anticoagulants. And who can blame them? Warfarin is a very difficult drug to use. You have to tell them to take their diets, to worry about their diets and their drugs, whereas the novel anticoagulants are much easier to use. You can just stop it for one day to get a procedure and restart it the next day, so there's no 5 or 7 days of stopping the anticoagulant. So I think that this slide is too premature to really see the 2014 guidelines made a big difference. I think the longer time we have the guidelines, I think that the better we'll see more use of anticoagulants. So I'm looking forward to that, to the verse. About patients on digoxin, a lot more women, as that slide showed, a lot more women are being treated with digoxin for rate control. And unfortunately, in one of the novel anticoagulant studies, the ROCKET AF looking at rivaroxaban, they showed that digoxin increased mortality. And unfortunately, women were treated with digoxin more frequently than, and they had increased risk of deaths and CV outcomes for the use of digoxin in patients with with atrial fibrillation. Sin, unfortunately, is getting more bad press. There were studies to show that there was no big difference in mortality, but many studies are showing there is an increased risk of mortality with the use of digoxin. The most recent articles that are alarming is the use of digoxin and the incidence of the risk of breast cancer. And in this WHI study, which looked at almost 100,000, more than 100,000 women, that they had a 5.7 incidence of invasive breast cancer, which is a 19% increase risk of invasive breast cancer compared to patients who are not on digoxin. You just look at the use of digoxin in patients with atrial fibrillation, it was actually a much higher risk of up to 68% risk, the hazard ratio of 1.68. Another study that looked at many studies using digoxin for atrial fibrillation, this study looked at the risk of the use of digoxin and the risk of not only breast cancer but colorectal cancer. What it showed was that it didn't increase the risk of colorectal cancer, but it did increase the risk of breast cancer. So I'm going to magnify that, and this slide will show you that in patients who did not have atrial fibrillation and no cardiac glycosides, that was control. But to add atrial fibrillation alone, it didn't increase the risk of breast cancer. But if the patient had atrial fibrillation and was put on cardiac glycosides like digoxin, there was 70% increased risk of breast cancer. If they have atrial fibrillation, but they were given cardiac glycosides like digoxin, there was also a 69% increased risk. So these two studies were just eye-opening for me because I treat a lot of patients with atrial fibrillation, and I treat a lot of women, and I discuss this with them. And it's interesting that my female patients, they didn't really care too much about the increased risk of mortality, but they did care about the increased risk of breast cancer. And I've been able to stop digoxin in a lot of these patients when I told them the risk about breast cancer, which is an interesting observation in my patients. Anyway, just wanted to summarize that by showing that this meta-analysis of 14 control studies and 15 cohort studies showed this increased risk of breast cancer. And it's interesting, they found that it was not just all breast cancer, but it was the the estrogen receptor positive breast cancer that was increased. The estrogen receptor negative breast cancer was not increased, which makes me think that this is a finding. And as you know, digoxin causes an estrogen mimetic changes on the EKG, so that you then have STT wave abnormalities that are seen when somebody is put on digoxin. So unfortunately, I think it's not just working on the heart, it is also working on a lot of different organs. And since estrogen affects the breast, I think is affecting our risk of breast cancer. So I think we really need to take care of that. So I know that there were some questions about the left atrial occluder, so I'm going to do some brief summary slides on the two kinds that are actually available for our patients. So for patients who cannot be anticoagulated, they have either a high risk of bleeding or they've already bled from their GI tract and they cannot be on anticoagulant. What can we do to decrease patient's risk of stroke? One way we can do it is this left atrial appendage occluder, the lariat, which actually requires that they go through the chest and also intracardiac. They isolate the left atrial appendix and then lasso the pedicle of the left atrial appendix and just basically make it ischemic, and then it'll just die off. And so that there is no more receptacle of blood clots in the left atrium. The other one is the Watchman device, which is another left atrial appendage occluder. It's a little bit easier that you don't have to go through the chest using a surgeon, but the cardiologist, either an electrophysiologist or interventional cardiologist, would through the either the PFO, the hole between the septum of the atrium, or create a hole between the left atrium and the right atrium, and then advance this balloon through that hole and find the left atrial appendage, and then open up it's like a stand, like an umbrella, and it will actually lodge into the left atrial appendage. And eventually, after about 3 months, it will basically just endothelialize, so that you're basically cutting off the left atrial appendage from the left atrium. And patients who can be anticoagulated, this procedure was compared to the use of warfarin. And in this slide by Dr. Reddy, that was published last year, it showed that this Watchman procedure was just as good as being on warfarin. So I'm pleased that we can now offer this procedure for patients who cannot be anticoagulated and they want to have the risk of stroke reduced. They can be referred to cardiology for this procedure called the Watchman procedure. I did this procedure to one of my patients who were already on novel anticoagulants, and he is very compliant with his medications, and recently was to have, incidentally, a small stroke. And we discussed this with him, and we said that this is not part of a study, but we are seeing that you are having residual stroke on top of the novel anticoagulant, and we can put this device in your left atrial appendage and do even more. So we put this Watchman device in him, and we still continue the anticoagulant. And so I think that, that's a new population that we can look at in the future. I'm pleased to say that the study was done in 2017, that we can give comforting news to our patients that this Watchman procedure was just as good as warfarin. It has not been compared to the novel anticoagulants, and that study needs to be done as well. Just to summarize, how do we take care of patients with atrial fibrillation? As you know, patients who have an increased risk of stroke, and so we anticoagulate them. And the patients also have an increased risk of heart failure if they are not controlled in terms of rate or the rhythm. So we're going to rate control them and anticoagulate them, or control the rhythm by putting them on antiarrhythmic drugs and cardioverting them and keeping them on antiarrhythmic drugs and anticoagulate them. It's really up to you and the patient. Based on the symptoms of the patients, if they are doing well on rate control, we just leave them on beta blockers and calcium channel blockers that can control the rate and anticoagulate them. But if they're so symptomatic with the atrial fibrillation, then we tend to put on antiarrhythmic drugs like amiodarone or antiarrhythmic drugs that are appropriate for them, and anticoagulate them as well. So that's really up to you and your patient. So I think I'm going to, Renee, are you there?
So you can go to your next slides, and I'm going to be speaking about Get With the Guidelines in a few moments.
Okay. So the goals of this Get With the Guidelines that we're doing with the American Heart Association, really to make sure that patients who have atrial fibrillation are getting the best quality of care. And we would like to just get with the guidelines for atrial fibrillation. They've been very successful in helping patients with myocardial infarctions and stroke, and the American Heart Association has now started this Get With the Guidelines for atrial fibrillation because it's such a big problem for patients. So the goals of the Get With the Guidelines for atrial fibrillation are, of course, to improve the quality of care, improve the adherence to anticoagulation, improve the patient adherence to anticoagulation therapy through education, and improve the heart rate control in patients so that they don't develop heart failure, and assure that the quality drug therapy is the best quality in patients with atrial fibrillation. One other goal is to improve the outcomes of patients with atrial fibrillation by assuring adherence to the treatment of other diseases that affect atrial fibrillation. Make sure that patients with coronary artery disease are on beta blockers and statins. Make sure that patients who have heart failure are on ACE inhibitors and ARB medications and beta blockers for CHF. And of course, making sure that patients who are smoking get counseling and therapy for tobacco in these patients. As you know, the 2014 guidelines were published in 2014, and Dr. Craig January was the lead author of this. And this is, we're going to go over briefly some of the guideline that was mentioned in this article, published in December of 2014. Just quickly go over some of the definitions. But I wanted to give you this slide to tell you that you don't decide on anticoagulation based on the type of atrial fibrillation the patient has. So whether the patient has paroxysmal atrial fibrillation or permanent atrial fibrillation, or they require antiarrhythmic drug, stay in sinus rhythm, but they are called persistent atrial fibrillation, need to be anticoagulated based on their CHADS VAS score, the type of atrial fibrillation that they have. So briefly mention, paroxysmal means that they are just on beta blockers or calcium channel blockers or digoxin to keep them in sinus rhythm. Persistent means that they need antiarrhythmic drugs, and they have atrial fibrillation that is sustained for greater than 7 days. Paroxysmal atrial fibrillation less than 7 days. And then long-standing persistent atrial fibrillation, continuous atrial fibrillation for more than 12 months, and then permanent atrial fibrillation or chronic atrial fibrillation is that you and the patient have decided that you are not going to convert them. You're going to keep them in atrial fibrillation, and that the patient accepts this treatment. So interesting that in this guideline, they really want us to talk to the patients and decide with them whether they're going to accept that the patient is going to remain in atrial fibrillation. You could look at that permanent atrial fibrillation. Acceptance of AFib or AF represents a therapeutic attitude on the part of the patient and clinician rather than an inherent pathophysiological attribute of the atrial fibrillation. So we convert almost every patient with atrial fibrillation, but it comes at a cost of being usually on amiodarone, which has a lot of side effects. And so this is a conversation we'll need to have with our patients, whether we would rather accept. If the patient is tolerating the atrial fibrillation, there is no reason to keep shocking them out of that because they actually will do fine. They don't have an increased risk of mortality or stroke if they're anticoagulated and their heart rates are kept in a good rhythm. I'm not really going to go over the mechanisms of atrial fibrillation. Atrial fibrillation is caused by a lot of different things. Just to let you know that hypertension is a big risk factor for atrial fibrillation. So on the upper left-hand corner of the this slide, just wanted to point out hypertension, obesity, sleep apnea, and hyperthyroidism are major risk factors. And I always emphasize that alcohol is a major risk factor in patients with atrial fibrillation, and that I'm never popular at cocktail parties because a lot of my friends and my colleagues drink a lot of alcohol, and especially if they're men and they're tall, at high risk for atrial fibrillation if they drink more than 2 or 3 drinks in one setting or in one day. So just to reiterate that how important those risk factors are for atrial fibrillation. So this is the recommendations by the guidelines. I'm not going to go over all these. You can read these at your leisure, but there are Class 1 in the green, Class 1 recommendations for patients with atrial fibrillation. I'm not sure you can see that, but the CHA2DS2-VASc score of 2 or more is a Class 1 indication, and they recommend the use of warfarin or no anticoagulants for atrial fibrillation. For rate control, there are Class 1 recommendations, just the use of beta blocker and non-dihydropyridine calcium channel blockers like cardizem and verapamil for use to slow down the rate of patients with atrial fibrillation. Patients with atrial fibrillation and heart failure, there's still a recommendation for digoxin, but you really need to make that decision yourself. And digoxin is not recommended for heart failure in terms of mortality, but some people do feel better with digoxin. And the one thing I've learned is that if you are going to use digoxin, use the smallest amount possible and check the levels to make sure they are never going above 2, because that's when you start to see increased risk of digoxin use in these patients. There's also recommendations for electrical and pharmacological cardioversion, so that you have to wait about 3 to 4 weeks before you shock a patient who has atrial fibrillation that's more than 48 hours. And if you don't know how long the patient has been in atrial fibrillation and you want to convert them by shocking them or giving them antiarrhythmic drug, you need to give them therapeutic INRs with warfarin, or have them be extremely compliant with their novel anticoagulant for at least 3 to 4 weeks before you even anticoagulate, or before you even shock them. So there are different strategies depending on whether the patient has normal hearts or not normal hearts when we decide on antiarrhythmic drugs. I'm not going to go over this because electrophysiologists are usually the ones who are deciding on the antiarrhythmic drugs. So those are the summary of recommendations. There are some specific patient groups that are also included in the recommendations in the guidelines, so I'm not going to discuss this, except for the patients who have hypertrophic cardiomyopathy. These are, actually it's more common than we used to think. There's about 1 out of 500 people who has hypertrophic cardiomyopathy, so it's a lot more common than we thought. And those patients with atrial fibrillation and hypertrophic cardiomyopathy should be anticoagulated no matter what their CHA2DS2-VASc score is. There are patients with familial genetic cause of atrial fibrillation, and they have a 2B recommendation for anticoagulation for those patients, but those should be referred to genetic counselors. There are also recommendations specifically for people who have acute coronary syndrome. So somebody comes in with an acute MI and they also have fibrillation. Well, they will need dual antiplatelets and their anticoagulation. So for a short period of time, depending on what kind of stent the patient gets, they need the triple blood thinners, is what we call them. There are also different diseases that can increase the risk of atrial fibrillation, and so that's included in the guidelines. Hyperthyroidism, pulmonary disease, and WPW should be treated accordingly. Patients with heart failure should also be included in the guidelines. Patients with right ventricular response should also be treated differently, depending on what kind of structural heart problems they have. There are also new guidelines. This doesn't go into all the nuances of how to bridge patients who are on anticoagulation if they're undergoing cardiac or thoracic surgery, or also atrial fibrillation after cardiac and thoracic surgery. So there are guidelines for all of these different things. So I think I'm going to turn it over to Renee to talk about the Get With the Guidelines atrial fibrillation strategy. Renee?
Yeah, thank you, Dr. Volkman, and thank you for that wonderful overview looking at the history of AFib and helping understand the differences in the disease burden between men and women, and especially in the differences in treatment. And also, of course, going into really emphasizing the importance of monitoring and improving quality of care. And thank you for your overview of the current guidelines. So we heard about the guidelines, and I did want to share some information about American Heart Association's Atrial Fibrillation Quality Improvement Program. So the program helps hospitals adhere to national guidelines. It includes real reports, benchmark capability for looking at aggregate data for statewide, nationwide, and also regional and perhaps hospital system-wide. So quite a bit that you can do in this tool in terms of reports. We have a national recognition program, recognizing hospitals that practice according to national guidelines. The tool with the guidelines also includes our newer ablation data collection tab that comes with associated reports. And lastly, one of the great outcomes of this tool is the sharing of best practices. This, through Get With the Guidelines AFib, through all of our Get With the Guidelines products, we've built to really showcase hospital best practices on our website, also in webinars and in other venues. So more about the tool, I've included my contact information and also the contact information for your local quality improvement director in the slides that we will send out after this webinar. The measures that are included in Get With the Guidelines, this is a sample of all the measures available, and this is what hospitals can use to help them see how we're adhering to guidelines and to look for areas of improvement. And just a sample of the measures we have available in our reports tool. To share a few American Heart Association resources. These are links to some AFib specific resources for professionals, also for community, really trying to raise awareness and especially looking at the risk between AFib and stroke. A resource is your local quality improvement director to come to hospital or your organization, share information about American Heart Association and the AFib tool, and also to do a demo if that's something that would be useful for your team. So please reach out if you have any questions or if there are any resources that you're looking for that aren't currently here. And before we get to questions, we have a few upcoming events related to AFib. May, of course, is Stroke Month, and so we have many sources, just, of course, focusing on the relationship between stroke and AFib, strokeassociation.org website. We have an excellent AFib webinar coming up in June that will be hosted by my colleague in Indiana, Greg Poe, and it's going to be featuring Dr. Dan Moody, the medical director from Indiana University Cardiac Electrophysiology. So click on the link and we'll follow up to this group with a save the date. And if we have our American Heart Association scientific sessions coming up in November. So I have to open the floor for questions, and I believe our operator is going to give us some instructions for how to unmute your line.
Thanks. We will now begin the question and answer session. If you'd like to ask a question, please press star followed by number 1. Please mute your phone and record your name clearly when prompted. Your name is used to introduce your question. To withdraw your request, press star followed by number 2. One moment, please, while we wait for the first question.
While we're waiting for that question, there were some questions submitted ahead of time, and I think many of them were content of the presentation. But Dr. Volkman, there was one question that came up about, focused on the heart failure population, how to keep an AFib patient with heart failure out of the hospital. And participants mentioned that many of their heart failure readmissions burn with AFib. Speak to that?
Sure. Thank you for that question. I think that for patients with heart failure as well as atrial fibrillation, the rate control is one of the most important things that needs to be done for these patients. So obviously the patient needs to be seen a few days or a week after they've been admitted, just to make sure that they understand what the medications they're supposed to be on. And the important things to do is make sure that you get an EKG to what the heart rate is of the patient. You don't just get a pulse to decide what the rate is, because if the EKG is showing that it's a lot faster than their pulse, that means that they're not getting enough rate control. And the number that you want to make sure it's always below is 110 if the patient is asymptomatic. But if the patient is still feeling palpitations, you need to rate control them better. And of course, you're going to use beta blockers once that they tolerate, or Tilazem or Verapamil. Those are two kinds that you should use. If the patient has heart failure, just the use of digoxin. Like I said, I don't usually like the use of digoxin. Usually you can use beta blockers and calcium channel blockers. The one thing I would say is a treatment that is often not used soon enough, because the thought of doing an AV node ablation in patients with permanent atrial fibrillation is not thought of often enough. These patients don't always feel good when their blood pressures are too low on the beta blockers or calcium channel blockers, especially if they have heart failure. Think about referring that patient to an electrophysiologist for an AV nodal ablation and pacemaker. All patients will thank you for doing that because they feel better, being less medications, and their heart rates are regular and slower. So it's one approach that I would recommend to prevent those heart failure readmissions.
Well, thank you. And have any additional questions come in through the line?
We don't have any questions in the queue. Once again, to ask a question, please press star followed by number 1. You will be prompted to record your name. To withdraw your request, press star followed by number 2.
Hey, there was, I think, another question about superiority of or differences in the novel anticoagulants. We've discussed the advantages of the novel anticoagulants over warfarin, but we didn't really talk about the different novel anticoagulants. Many studies to look to show how effective these novel anticoagulants are. All of them are compared to warfarin. There were no side-to-side comparative studies of the novel anticoagulants, but they do have some nuances. I would decide on the novel anticoagulant based on what the insurance company the patient has, because these are expensive drugs, and you'll get more compliance with a patient as long as they're not paying too much for it. I think that was a big, we did a survey on whether patients would be willing to switch to novel anticoagulants from warfarin, and the biggest reason a patient will not switch is for cost. I mean, it's just a part of our lives that we don't want to pay too much for anything. But if you compare the advantages, they're almost all about the same. There are some nuances, like Eliquis has better mortality data, they have better stroke and bleeding data, but for if you look at all the real world data and the studies that were done comparing it to warfarin, there really is not great a difference among the different anticoagulants. The one thing that Doxaban has is that they studied in patients with renal failure. Of course, no one on dialysis can be on these novel anticoagulants unless the patient is really desperate, and there are some people who have used that. But for the most part, you cannot use novel anticoagulants in patients on dialysis.
Thank you, Dr. Volkman. And I think we're at the top of the hour, so I'm going to go ahead and close the floor for questions. But again, wonderful presentation. Thank you for that patient-centered perspective as well. I think that's very important. So thanks to all the participants on the line. We will be following up with some information about upcoming webinar. So again, a wonderful weekend, and thanks, everyone.
Thank you. Thank you, everyone. Bye-bye.
That concludes today's conference. Thank you for participating. You may disconnect at this time.